Good evening, everybody. Thank you. Welcome to a Compass to Care MS program. All right, this is an event. This is a series of programs created by MS Views and News. We are the only ones in the country that have the label Compass to Care, and we're doing these types of events, again, in different portions of the country, simply because we are providing things that concern the other aspects of multiple sclerosis. It's not always about the drugs that you see at many programs, but there are many other things that are going on as well. So like tonight, in addition to Dr. Hemphill, we have Dr. Gretchen Hawley, who's a physical therapist, and she'll be speaking to you about things to do with physical therapy. All right? Moving along quickly now. This program tonight, I want you all to know that we're being supported by Sanofi Genzyme and Celgene. If you don't know Celgene, you'll be hearing more about them in the coming months. Sanofi Genzyme you do know about, and again, they are the supporters of tonight's program. Tonight's event, as I said before, Dr. Gretchen Hawley is here. She'll be speaking for 35 minutes, and then we're going to do a 20-minute Q&A. Following Dr. Hawley, following her Q&A, Dr. Hemphill will speak for approximately 45 minutes, and then we'll do a 30-minute Q&A with him. All right, so next we have Dr. Hemphill. And Dr. Hemphill is a graduate of Baylor College of Medicine and did his residency training in neurology at the Johns Hopkins Hospital, where he did a research fellowship in movement disorders and was assistant professor of neurology. In addition, he studied bioethics as a Rockefeller Fellow at Harvard University and received an MBA from Emory University. He's board certified in neurology with special qualification in child neurology and is a fellow of the American Academy of Neurology. Dr. Hemphill has practiced with Savannah Neurology since leaving Johns Hopkins in 1981. Let's welcome Dr. Hemphill. He's coming in from all the way across the room.
Thank you. Thanks to everyone for coming. It's a big week in Savannah. The parking lot's full outside. I see some of you in green, some in orange. I've got my green, and you can't see it, but orange tie. So I've got the green on for St. Patrick's Week, but orange for MS Awareness Week. So good for those of you who have orange on. I look forward to seeing you at the MS Walk in May, and hope all of you can turn out. We always have a great time at that. I think that the topic of physical therapy was great for discussion. I think that was a fantastic discussion, Gretchen. People often ask me, what can I do to make my memory better? And there are online things you can do, or puzzles and that sort of thing. Turns out the best thing you can do for your memory is to get physical exercise. And so I've had to do that for myself, and so I try to practice what I preach, but the answer is to get out and get physical exercise. So the best thing you can do for your mind as well as your body is to exercise. So it's just an excellent discussion, and I hope you'll take all of what Gretchen said to heart. I'm going to talk about the medical aspects of MS. Many of you have been to the talks that I've given on the pharmaceuticals that we use for MS, disease-modifying treatments. So what we're going to talk about tonight are a little bit of the understanding that we have of MS, the medical terminology that you hear thrown back and forth sometimes but don't get a chance to ask about, and talk a lot about the symptoms, the individual symptoms of MS and what we do to manage those. And so I'd like for you to think about your own situation and think of questions you might have in general, not about specific questions about your recommendations from a physician to a patient, but just in general, the discussions that or the questions that might provoke. These are some slides that a couple of medical students helped me put together, because my slides are always in black and white and look terrible. And so I said, give me something colorful, and boy, they did. So they're busy. They've got a lot of stuff on it, but colorful. For those of you who've heard me speak, you know that I always try to drive home the points about what causes MS with three words, and that is autoimmune, central nervous system, and myelin. if you understand what those three words mean, you have a pretty good basic understanding of what MS is. First of all, MS is an autoimmune disease. There's lots of autoimmune diseases. Autoimmune diseases, for reasons we don't entirely understand, tend to affect people in the same sort of age group as people who get MS. That is, women between the ages of 20 and 50 or so. A lot of thyroid problems are autoimmune in origin. Lupus is one of those autoimmune diseases. Rheumatoid arthritis is another one. So there are a lot of autoimmune diseases out there. MS is one of the neurological autoimmune diseases. You may have heard of some others, such as myasthenia gravis. So autoimmune diseases can really attack any system, where the heart, the lungs, the kidneys, but MS is probably the best known of the disorders that affect the nervous system. Whenever an autoimmune disease occurs, it means that the body's immune system has been misdirected. Now, the immune system is here to protect us from bacteria, viruses, outside invasion. It also protects us from inside growth, so it's very helpful to suppress cancers that grow inside us. Our own body's immune system keeps them from growing. Some of the newer cancer therapies, in fact, are directed towards strengthening our own immune system to suppress it so that the tumors don't grow. And so when working properly, our immune system functions to help keep us healthy by keep us from getting infections and keeping from getting tumor growths. In the case of autoimmune diseases, what happens is that for reasons that no one really understands, there's a spark that occurs, and the immune system starts to get active. It starts to fire, and it gets misdirected. Instead of attacking some outside invader, there really is no outside invader. There really is no cancer growing inside. It just spontaneously starts the inflammatory process directed toward our own tissue. In the case of MS, that tissue that's affected is myelin. Now, myelin is the insulation material that occurs around the nerve axons or processes, which you kind of see pictured here. And the myelin sheath helps the conduction of the electrical impulse down the nerve, and functions much in the same way that the insulation material functions around an electrical cord. If you wear out the electrical cord in some place, or the cat eats through the cord, you can't get the light to turn on. The electrical impulse won't cross that gap and do what it's supposed to do. And the same thing happens whenever you get the myelin sheath exposed. The electrical impulse won't get across that gap. Now, this is what it looks like whenever we get the antibodies or the lymphocytes directed against the myelin. Instead of getting a nice clean myelin sheath over the nerve axon, what you get is a sort of ragged, torn area with a naked exposure of the nerve, and so you don't get good conduction across there. So you get an autoimmune process in which the immune system attacks this tissue, the myelin tissue, and causes this kind of scar. And it's these scars which we see in the brain and the spinal cord in people who have MS and who die and have autopsies. And this is what the French neurologists saw back in the 1870s and 80s when it was first described. They were doing autopsies, and they could actually feel these hard plaques, they call them, in the brain, that they call sclerotic plaques in French. And that's where the name multiple sclerosis came from. The fact that these scars that are left, and which we can see very well, as we'll talk about on the MRI scans, actually are firm to touch, and you can see them and you can feel them in the brain tissue in someone who's had MS at the time of autopsy. So this is the basic destructive process that occurs with misdirected autoimmune inflammation. Now, it's important to understand that this only occurs in the central nervous system. It does not occur in the actual nerves that go to your arm and legs. So even though you may feel tingling, numbness and tingling in your hands and your feet, the physical nerves that actually go to your hands and feet and come from your hands and feet are actually quite normal. The problem lay in the central nervous system. So that's the brain and the spinal cord. And it turns out the nerves from the eyes, the optic nerves, are projections of the brain. They're just extensions of the brain. So that's part of the central nervous system too, because the optic nerves, which carry vision to the brain, are actually part of the brain itself. So only the central nervous system is involved with MS, not the peripheral nervous system. So sometimes I'll give the analogy of I-95 and the exits. So MS it backs up traffic on I-95. If you can get past all of that and get to the exits are fine. So the exit to your house may work just fine. And so MS is basically traffic jams on I-95, but everything else is okay. The brain and spinal cord is where the problem occurs. Once you get out to the peripheral nerves, everything looks okay. So this is a basic understanding of what MS. There's a whole lot that we can drill down into when talking about the actual cellular physiology of MS. I think there may be a slide on here in a minute, and talking about how the immune system does this. Now, the question of who gets MS is something that's actually changing. And I've got to change this slide now because we now have new information. Just this past month, new information has finally been published with the sponsorship of the MS Society, showing that there actually is closer to about 1 million people in the U.S. who are affected with MS. We've known this for a long time, just knowing what our local population is, and everybody's experiences pooled together has led us, those of us who treat patients with MS, to know it was more common than what had been projected. And what you see here, this is the number that's been around for 25 years. But now the new number is closer to 970,000 people in the U.S., or close to 1 million people. In the world, it's I think that number, the 2.5 million, obviously goes up as well. Nobody has done any kind of recent research to give us a new number, but it's obviously going to be more than that. The global distribution has always been sort of unique to MS, and it's sort of raised the question of whether there's some connection between the way the geography is distributed among patients with MS and what MS is or what causes it. And that is the fact that MS occurs more commonly the further away you get from the equator. We don't know why that happens. In the northern hemisphere, that means that people in Canada and the northern tier of the U.S. tend to be more affected than people who live in the south, or people live in the Caribbean. In the southern hemisphere, it's people who live, for example, in southern Africa, southern Australia. So areas that are further away from the equator for some reason are more affected. And it's been speculated that maybe this has something to do with viruses that people are exposed to when they're young, because it depends on where you grew up until you're 15. So you can't move after you're 15 and change your risk. It's where you grew up that determines the risk. But we know that, I think the numbers in Scotland is, if you live to be 80 years old, there's about a 5% chance of getting MS. So it's much more common in northern latitudes in the northern hemisphere. So people have tried to use that to try to help understand what the disease is. Obviously, one of the things that came up was the question of whether or not maybe it's related to vitamin D. We know that people who live further away from the equator don't get as much exposure to vitamin D as people who live near the equator. So the question came up, is maybe vitamin D is due to MS is due to vitamin D deficiency, but turns out that's not the case. But along the way, we found out that people who have good vitamin D levels do better than people who have low vitamin D levels. That's why virtually all of you who have MS get your vitamin D checked as part of your blood work, and if your vitamin D level is low, have most likely been told that you need to be on vitamin D supplements. It's an easy thing to do, no side effects from it, and something that you can do along with a lot of other good preventive measures such as not smoking and practicing healthy habits, getting exercise and such, that you can do for yourself to help protect you from MS. So this geographical distribution of MS sort of helped give us some understanding about that led to that, but it really hasn't helped us about the understanding of why the immune system gets turned on and gets misdirected with MS, and that is still being pursued actively by lots of people, and that's what most of our research is directed toward. Now, this is the slide that gives a little bit of this, goes into down into the weeds a little bit about the cellular biology of what happens with MS, and shows that the cells called the lymphocytes that are in the blood, going back and forth, that are the cells that are what are called memory cells. So when you get vaccinated, basically you're teaching your immune system to recognize that virus. So if you get the flu shot every year, it's telling your nervous system, hey, this is a new strain of viruses. We're basically giving you sending you photos of what we look like, what the viruses look like. So if you see it back again, the immune system will know how to recognize it and come and knock it out. So these memory cells are what are important with MS because they're the ones that get misdirected. These T cells and B cells of the lymphocytes are what get misdirected and become active MS and cause the damage affecting the myelin. And what we think happens is that the lymphocytes within the blood cell, the blood system, somehow start to get activated. They then cross the blood-brain barrier because there is an actual barrier between the blood vessels and nervous system tissue that's stronger than the barrier in other organs. And so these, with inflammation, the pores open in the blood vessels, the lymphocytes get out into the brain and spinal cord tissue and actually cause inflammation. And so if you were to take a microscopic picture of the tissue here where the cells get into the brain, you would see that there is actual, as they cross the blood-brain barrier here, you would see that it's the sort of the microscopic correlate of red, angry, swollen tissue that is what happens whenever a relapse or an inflammation episode of MS occurs. Now, because there's an opening in the gaps here, we'll come back to this in a few minutes when we talk about the MRI scans with contrast. So most of you know when you get MRI scans, you usually get a contrast injection, right, in your arm. And the reason that's done is because we can kind of detect if there are leaks in this blood-brain barrier that indicate inflammation. And for just that period of time that there's inflammation, the contrast material will cross into the tissue, and we can see a little bit of staining going on there that tells us that there's active inflammation going on. So that's why the contrast enhancement part of the MRI scan is normal. This only goes on for a few weeks, so that's a relapse of MS. An exacerbation of MS is something that comes and it goes, and it's gone within a short period of time, and this inflammation we know is gone, and the period of time that we see the abnormalities on the MRI scan that indicate inflammation only lasts for a short period of time. So this comes and it goes. The problem is that it leaves the scars that we talked about before, at the area where the myelin was injured, and so it's this scar that's left over from the inflammation that leads to the footprints that we see on some of the other parts of the MRI scan, the T2 lesions as are discussed, that lead to sort of the hallmark of MS. So lesions, you've heard the word lesions before thrown around a lot, so you probably wonder, what in the world are lesions? So lesions are where the inflammation cells have gotten out and have actually attacked the nerve cells. So the lesions are that area where the inflammation has occurred. That's where the pathology is. That's where things are not normal, where something happened that shouldn't have happened. That's what, it gets inflammation. As the inflammation then dies down, the body's reaction to it is to form scar tissue. That whole process creates what's called a lesion, and it's there permanently. Once it occurs, then lesions are scars. So just like you get scars, they may fade, but they usually don't completely go away. So the emphasis more and more on treating MS has been to prevent this inflammation in the first place. That's always sort of been the holy grail. And all of the medicines that we have for MS work toward preventing this kind of autoimmune inflammation directed at myelin in the central nervous system. So now you know how it happens, right? It's all clear. Clear as mud. So somebody here maybe can go and figure out the answer to why this autoimmune trigger occurs. It's going to, someone will win a Nobel Prize one day when they figure that out. Now I'm going to talk primarily about the symptoms, spend the bulk of the talk talking about the individual symptoms that occur with MS, because that's what people feel, and people have questions about how they deal with these things in their lives. And so I'm just going to go through system by system and talk about the symptoms that are manifestations of MS, so you know what to recognize, and kind of give you some order to understanding of what the symptoms come from and what they mean, and then talk a little bit about their treatment. Certainly the most common symptom we see from MS is the fatigue. And so we've heard about that already. We know that's just almost a global symptom, and we often ask patients to fill out questionnaires about fatigue, but almost, of course, it's a part of the human condition to have fatigue. But it's something that certainly that people with MS especially fight against. And so we don't understand why it happens. So it's not clear how these little lesions in the brain somehow lead to us feeling fatigued. There doesn't seem to be anything particularly wrong in the blood that causes it. The inflammation we know occurs only off and on. That's what relapsing MS kind of means. It's occurring off and on. So it's not there, the inflammation is not there all the time, so we don't really understand why the fatigue occurs, so that's why we don't really have a specific treatment for it. We know that maintaining your physical stamina, as Gretchen talked about, is critically important. We know that sleep is very important. And we know that mood is very important. So if you're depressed, you're going to get more fatigued than if you're not. So what we do as physicians and neurologists in treating people with MS who have fatigue is try to look at these individual variables and help to promote health in each area. So we try to get people to increase their physical activity. We make sure that somebody doesn't have sleep apnea and need to be on pressure at night to help them to sleep through the night. We try to screen them for depression to make sure they don't need to be on an antidepressant medication. When we've been through all those things and still someone's feeling fatigued, we actually use a medication that's a stimulant that will help us have a little more energy. Now, those stimulants that we use are medications that have primarily been used in people with narcolepsy, people who fall asleep during the day and need something to keep them awake, and people with attention deficit disorder, things like Ritalin. So just know that whenever you ask your physician about a medication for fatigue, we usually try to do non-pharmacologic kinds of strategies first, and then we may go to a medication, because those are really the only medications we have, and we don't really like to prescribe those all the time, but they are the ones that we end up turning to if we have to. Cognitive impairment is something that we've realized more and more is a problem with MS as people get older. We know that the brain shrinks in all of us a little bit every year. So once you hit about 16, it's all downhill from there. So once it finishes growing, then little by little, for all of us, it's decreasing, and then the statisticians and radiologists, they can tell you it's 0.3% per year or something like that. But we know now that people with MS lose brain volume faster than other people. So we're now building that into our MRI scans and such, and it's being looked at in the new medications being brought out as to how well an individual medication helps to slow brain shrinkage or brain atrophy over the years. And this has not gotten a lot of attention, I think, because, well, we hadn't been able to, measuring MRI, we haven't been measuring MRI scans for that long. The medications that are used, that are tested for MS, kind of like every other medication that's tested by the FDA, they're tested over a couple of years. They're not tested over 10 years or 15 years or 20 years. So almost every medicine out there is basically kind of, what have you done for me lately? What can you do in a short period of time? And that's how the MS drugs get tested before they come out. So it's only after they've been out for 10, 15, 20 years that we can kind of see what difference they make. But we now, after we've been able to see people treated for 25 years versus people who've not, we see that people who have been treated, and the better they've been treated, the more aggressively they've been treated, the better they do better than people who've not been treated in terms of their memory and cognitive function, their brain volume, these kinds of soft signs, invisible kinds of symptoms and signs that Stuart was talking about. That, along with fatigue, are part of the picture of MS in people, especially who get into their 50s and 60s and 70s. So we think that MS is sort of promotes the aging process, and one of the reasons why your neurologist, your physician may want to make sure they're getting the most to you for what you have is to make sure they're really looking out after you 20 years down the road. Well, right now I feel okay and I'm doing all right, but we want to make sure we're doing everything we can to make sure that you're still on your toes and not having memory and cognitive issues as you get older. So we're paying more and more attention to cognitive impairment now, even early on in individuals with MS. We know that mood disorders are more common in people with MS than in the average population. So, as I mentioned, for fatigue, one of the things we look at is depression, but in general, we look at people's moods. And that's why part of the reasons it's helpful to have your family member or your care partner come with you when you come for your neurology visits, because we're going to, and when you go to your primary care visits, because one of the things that we'll ask about is your mood. How have you been feeling lately? And your care partner may tell on you. And so you're not willing to say, I've been bluing down the dumps. And so your partner may say, you know what, right, she's been irritable, or she's been tearful, or things have looked hopeless and whatnot. But people don't, in our culture, we don't want to talk about things that often. So sometimes we have to pull it out. But it's important because that is something that we can treat with medication. That is something we do something about. Exercise does help prevent depressed mood, so we can encourage that. So we are, again, recognizing that people with MS have more of an issue with mood than we previously understood, and because it's so treatable, we try to make sure we discover it if it's there. So those are sort of some of the issues that come from brain involvement from MS that we're understanding more and learning better how to address. Vision symptoms have always been a classic feature of MS. So many of you may have had visual symptoms as part of your MS, and that may have been how it was brought to diagnosis. The most common that we see is a condition called optic neuritis. Now, optic neuritis is an inflammation of the optic nerve. And you heard me say earlier that the optic nerve is an extension of the brain, so that's why it's involved, because you know now that MS only involves the central nervous system, and the central nervous system is the brain and the spinal cord, not the individual peripheral nerves. But the optic nerve is an extension of the brain, so it counts as the brain and not as a nerve, if you get all of that. And so optic neuritis is an inflammation of the optic nerve, and it's particularly exposed and particularly involved and typical of people with MS. So virtually everyone who has MS and goes to see the eye doctor because of blurring of their vision will get sent to the neurologist or get sent for an MRI scan to look for MS because it is so common. Now, the symptoms of optic neuritis really consist of a blurring of one eye. So it only affects one eye, not both eyes. It's very rare for both eyes to be involved at the same time. That kind of suggests something else is going on. But it's usually one eye, and people would think I've heard people say, I thought my contact lens was dirty, or my glass was dirty on that side, or something happened, I had a film over my eye. That's a very common thing for people to describe. But the main thing is that it's monocular, or it's in one eye only. So again, of course, the usual path is for people to go to see their eye doctor, and the eye doctors are almost always well-trained in recognizing this. And as I said, if they see it, they're going to refer to the patient's physician or to a neurologist to get evaluated further. So optic neuritis is one of the most common presentations of MS and one of the most common occurrences. And so that's one of the things you want to be able to recognize. The other common visual symptom that occurs is double vision. Now, this primarily occurs when you're young, sort of like the optic neuritis, when you're 20s and 30s, not so much when you're older. But again, I just had a patient in the hospital last week who presented with double vision. And sure enough, he had the typical feature of one eye not moving as well as the other eye, which was causing his double vision. He had something called nystagmus, where the eyes were beating to one side and then the other. This particular problem we call internuclear ophthalmoplegia, or INO, so that kind of gets down in the weeds neurologically, but it's the classic lesion of MS, so I could tell by looking at him that he most likely was going to have MS, and sure enough, that's what showed up on his MRI scan. So double vision of any kind is something that you want to see your eye doctor or your primary care physician or your neurologist about to explore further. Speech usually is not a primary problem. It's usually a secondary problem for people who have what's called ataxia. Now, ataxia is a term really probably everybody with MS kind of ought to know about. It is a technical neurologic term, but it is the word we use for poor balance, poor ability to kind of go where you want to go, poor ability to reach for what you want to reach for. The part of the brain called the cerebellum is there to help us judge distances. So that's what helps you to shoot a basket, to throw a spitball into the trash can as a student in school. To be able to meter the distance between yourself and an object further away. It also helps with rhythm. And so the rhythm of speech tends to get altered if you have MS, and you may have heard a lot of people with MS who have difficulty with prosody or being able to keep the rhythm of their speech, and that's because of this problem of ataxia affecting the cerebellum, the back part of the brain, and also it will cause a tendency to have difficulty with balance, maybe a broad-based gait, and difficulty pointing or reaching from one thing or another. They're all kind of related into that one big picture of ataxia. Fortunately, swallowing problems are not very common with MS, so unless somebody's really severely affected, we don't see it very much. Now, the other most common symptoms that we see are symptoms from what I've described so far are symptoms involving the brain. The other common symptoms that we see of MS involve the spinal cord, from the neck down. And so those problems are weakness, pain, numbness and tingling, and bladder problems. And weakness, obviously, is something everybody kind of recognizes right away. If you're dragging your leg, if you have a foot drop, as Gretchen described, if you've become clumsy with one hand, those are symptoms you're going to recognize pretty quickly. The ataxia I mentioned earlier may sometimes occur because there's loss of sensation in the feet, so you don't really know where your feet are. Associated with that may be other sensory symptoms such as numbness and tingling, or even a burning kind of pain. So although all of those may be due to problems in the spinal cord. Bladder problems are very common with MS, and that's why Gretchen mentioned to you, or I think Stuart was mentioning having a urologist here next year, somebody that Gretchen may have on her virtual program. But urologists are very important in assisting us with the care of many patients with MS, because if you have spinal cord problems, then your bladder may have difficulty functioning. There's nothing wrong with your kidneys. It doesn't have anything to do with your kidneys. It just has the to do with the ability of the bladder, which is this sort of big baggy muscle. It keeps it from contracting properly and emptying itself of urine or water fully, and so you sort of have a little stagnant pond left in there all the time, and it can get infected, and that can cause problems with the kidneys. So the urologists are very important in helping people to treat their bladder symptoms and empty their bladders properly, both not only for comfort, but also for treating infections and preventing any kind of kidney damage. So these are all of the important symptoms that can occur with MS, especially with MS exacerbations. Some other problems are sort of there long term. Obviously, pain can be there. Spasticity, which you heard Gretchen mention in talking about physical therapy, is something that we manage not only with physical therapy, with medications. And so some other things like that come about, all as sort of part of a secondary feature of things that can happen acutely with MS. But they're all areas that everybody should be familiar with. The problem with walking is probably the most common, the most typical feature of MS. It's the one it's most known for. We do have some medications that we can use to help people with walking. And whenever you come for your visits, certainly with us and with most neurologists, you'll be asked to kind of walk for 25 feet to see what your speed is, because over time, if we see that that speed is beginning to drop, we know something's happening with your walking. And on studies, people sort of before the era of understanding about cognition and such, people always replied that walking, the ability to walk and preserving that ability was really the most important thing they valued in treating their MS. And so we've really put a huge emphasis on walking as something that we want to be able to preserve, the ability that we want to preserve the most with MS. And it's probably the most common measure that we use in determining whether somebody is having problems with their MS or not. So certainly talking about your ability to walk, the observations your caregiver, care partner may observe in watching you walk are very important to us as we try to assess how you're doing with your MS. And in addition to physical therapy, as I said, there are medications and other things that we may want to do as well. But it's certainly one of the most common reasons why we may refer somebody for a physical therapist, not only just to have the ability to walk, but also to prevent falls and the complications that can occur along with that. So these are just a sample of the many symptoms that can occur with MS, sort of what they're like, and a little bit about what we may do about them. There are a couple of other phenomena that we teach the medical students. I use these same slides to teach the medical students about MS. One symptom that many of you may be familiar with is if you flex your neck, you feel like an electrical sensation goes into your shoulders or goes down your back. That's called Lhermitte's sign, because the Professor Lhermitte in Paris described it initially, and a lot of famous physicians over time have had their names put on these signs that they describe. The other one is the sign that Gretchen referred to in talking about the summer heat, and most people in Savannah are familiar with, and that's called Uthoff's phenomenon. So what Uthoff described was that if you got overheated, your MS symptoms come back. So for example, if you had optic neuritis before, it got better, felt like everything was doing fine, but then you get out in the 100-degree heat, or you get an illness with a fever and your body temperature goes up, your vision, your blurred vision comes back again. And you think, oh no, I'm having an exacerbation. And in fact, this is one of the most common things that we have to do in our practice, is have nurses on the telephone talk with patients to talk through these episodes, often called pseudo-exacerbations, when they call and say, my numbness and tingling's coming back, my blurred vision's coming back, my walking's getting worse. But we talked to them and found out, this was just yesterday when I was working outside. Or it's just because I've had an illness and had a fever recently. I got overheated. Their and other physiological stressors, it's probably not just heat, but sleep deprivation and other things like that physiologically stress the nerve cells. And now that you know how MS occurs, you know that electrical impulse doesn't get conducted effectively in MS. And so if you stress it and try to push it to its limit to perform, it breaks down and it doesn't perform, and it doesn't conduct the impulse. Translated, what that means is that the function doesn't get done. So if it's visual function, the visual function is not normal. If it's sensory function, then there's tingling and burning and other things like that that occur. If it's strength, weakness occurs. And so people who live in climates where there's a lot of high temperature often experience these pseudo-relapses or Uthoff's phenomenon and feel that they're getting relapses, but they're not. It's really important to know that, because if you're having a relapse, that means your immune system is flaring up and your medicine is not doing what it's supposed to. If you have a pseudo-exacerbation or Uthoff's phenomenon, then your medicine's working just fine. You're not having a relapse. You're just experiencing the normal ebb and flow that occurs with increase in temperature and other stressors to your system. Just to tell you, it dates me certainly, but when I was first learning about MS, we didn't have MRI scans. And so the test that was done, there can't be anybody who knows this or experienced this. Anybody ever had a hot bath test? So the way we used to, just think about how high-tech an MRI scan is now, right? You get in this fancy machine, we get pictures of your brain. I think it's miraculous still. So what we used to do is take patients down to the physical therapy department and put them in a hot tub. And that way they used for burns and other things like that. And so they would put in temperature, water that's 106, 108 degrees. We would get people's core temperature up over 100 degrees and ask them if they had blurred vision. Ask them if the numbness and tingling came back. If they did, they said, "You got MS." We couldn't do anything about it at that time, of course, but we knew they had MS. But that was how high-tech things were when I first learned about MS as a resident. We've come a long way, baby, I can tell you. So that's the story of Uthoff's phenomenon. The diagnosis of MS now is made, now that you understand all this, is that we can demonstrate that there are these lesions that have occurred in different areas of space at different points in time in the central nervous system. That's what the multiple in multiple sclerosis means. So if I explain to you where the sclerosis came from the French word for hard, which characterized the plaques that they felt in people's brains at the time of autopsy. And multiple comes because there are many of them in different places, not only, and we knew even then, not only in multiple places in the central nervous system, but they occur at multiple points in time. And even still to today, and the way that we diagnose MS is to try to prove that neurological symptoms have occurred over multiple points in space and multiple points in time, or dissemination in space and time. And that's what we use. We use your clinical symptoms, and that's why we grill you on when you've had certain symptoms, and how we use the MRI scans, and why we may do the brain and the cervical spine, and why we can do the contrast. And then we know now that using the spinal tap and checking the spinal fluid is also a way of seeing if you've had a past problem. That helps to kind of satisfy the dissemination in time criteria, which is often hard to do in people who just presenting with MS symptoms. And that's one of the reasons why you may get a spinal tap when you get diagnosed. But nowadays, I can tell you again, when I was learning about MS and we didn't have MRI scans, we did lumbar punctures if you called in and said you were having an exacerbation. So how many people do you think called in and said they were having exacerbations? Okay, well, come on in and we'll do a spinal tap again. That's all we had to offer, and then we would increase their prednisone. So really nobody was too anxious to come in and tell us about their symptoms if we knew they had to be pretty bad. But we still use the lumbar puncture in the diagnosis of MS, but once you get it one time, that's usually it. You don't have to give it anymore. And lastly, I'm just going to talk a little bit about the MRI scan. Everybody's always curious about that. And I'm going to kind of get out of order and just first talk about the enhancing lesions, because this is the order to think about it, in the order we talked about with the pathology. So you now know, right? That an enhancing lesion means what? That's where inflammation is occurring. That's where the blood-brain barrier sort of broke down, and the lymphocytes, the cells got out into the brain and caused inflammation, and you see leakage of the contrast when you give it. And so it's kind of maybe hard with the lighting, but you can see a little area, a little faint blush right there occurring around a lesion. That means that there's active inflammation going on at the time. That means you are having an exacerbation if that happens, and that the MS medicine, the disease-modifying treatment you're on, is not effectively suppressing the immune system, and we may talk about a new medicine if these things are occurring. And as you learned already from talking about the pathology, you know that the lesions, the T2 lesions, are the scars left over from the areas of inflammation, right? And this is what they look like on the MRI scan. So these are called Dawson's fingers. And they sort of look like a hand or a glove that sticks up on these images, and they have a characteristic picture. So people often come to me and say, well, the radiologist saw some white spots on my brain, said it could be MS. Well, lots of people have white spots in their brain, but only the ones that look like this are most likely MS. So they do have a characteristic appearance, and this is what it looks like. In addition, if these become too dense and they coalesce, or too many of them, they can actually lead to holes. So they actually break down and cause liquid to accumulate in there. They become holes in the brain. They look like Swiss cheese. Those are called black holes. That's the end stage of the process. We don't want to ever get to there. But we have people we can see who've had MS for a long time, and that's what we see are the black holes. That's what causes the shrinkage in the brain atrophy we talked about. And then lastly, there's the spinal cord, which is a critical part of the MS story. That's where the walking problems usually come from. We don't do MRI scans as much of the spinal cord as we do the brain, because these symptoms are rarely ever silent. If you have a problem in the spinal cord, it's so small that there's really no silent territory. If you have a problem there, you know it. You've got numbness and tingling, you've got weakness, you've got balance problems, and so, but we will look at the MRI scan to get an idea of the overall lesion burden and kind of determine how you do. So I'm not going to go back and talk about the lumbar puncture anymore. I've said enough about that. But this hopefully gives you some idea about what MS is, about the symptoms that it causes, a little bit about what we do for them. At other presentations, we talk about the treatments. The purpose of this program is primarily to talk about navigating MS symptoms. And so I wanted to kind of lay these out there in more detail than we ever really get to talk about in the office or in a lot of the dinners that we do about the specific MS products. So hopefully this answers some of your questions about what you may experience with MS and how you present these in talking with your provider and what you can do about them.
Excellent, thank you.
So with that, we'll open it up for questions.
Awesome. Help me out here. Let's do this side of the room first, all right? Who's got questions?
I had a question. Recently, when I went to my eye doctor, I was talking with her about the floaters, and she said you can't tell the difference between MS and glaucoma. Is it seem to be more prevalent with MS or no?
Is glaucoma more present with MS? No. Is that what?
With the vision, when you look and it's like you see black dots floating around?
No, those are normal. That's just debris in the eye fluid, the gel called the vitreous. So floaters, we all experience floaters, especially the older we get little pieces that break off there in the vitreous, but that's not related to MS. And a good eye doctor should be able to tell the difference between glaucoma and MS and optic neuritis. So maybe get another opinion. I don't know.
How do you know the difference between if you're having a relapse or if it's like you just got too hot and you're just outside for a while?
Yeah, that was the thing. It was a good question. So an MS relapse is going to last days to weeks, not hours to a day. So it's longer. A relapse is going to be longer. An MS relapse is going to be a symptom that you haven't had recently. So if you tend to get numbness and tingling in your feet and legs, and you know it comes and goes every few weeks, that's not going to be an MS exacerbation. That's just your MS kind of showing its face and coming back and forth. Or if your blurred vision seems to be worse on some days more than others. So that sort of normal fluctuation of return of your usual symptoms is not an exacerbation. So MS exacerbations usually are new symptoms or something a little different than what you had before that lasts for a longer period of time. So strictly speaking, something you haven't experienced in the last 30 days and something that lasts days to a few weeks. Does that help?
I have a girlfriend that was recently diagnosed and is dying due to ALS. Can you tell me the difference between ALS and MS?
Yes. ALS, or amyotrophic lateral sclerosis, or Lou Gehrig's disease, is, as far as we know, it's just a degenerative disorder. It doesn't have to do with this inflammation, or at least not that we know yet. It's a degeneration that occurs of cells primarily in the spinal cord, and somewhat in the brain. But unlike MS, that's one of the differences. Actually, I'm glad you brought this up. It's one of the differences this is why I emphasize this whole central nervous system business and tell you your nerves to your arms and legs are okay, because that's what ALS does. ALS involves the brain and mainly the spinal cord, and it involves the nerves that go to your arms and legs. So there's a fundamental difference between the two. And we don't have any treatment for ALS.
So if you're experiencing old issues, should you go to and get like treatment, or get like cortisone shots, or not cortisone shots, but like I can't remember when you go to the hospital and you have to get steroids. So should you go back for
so the
question
old
ones?
Is, yeah, should you get steroids for getting your old symptoms coming back? Yeah, that's one of the reasons you want to distinguish it. It's not good to keep getting steroid infusions. And so we don't want to give them if it's just the Uthoff's phenomenon, if it's just your old symptoms coming back, because the steroids don't help. What the steroids do is they shut down this inflammation. Prednisone or Solumedrol, the steroids are the ultimate anti-inflammatory medication. So they shut down this inflammation. That's why we give them to you quickly if you call in and you have a relapse. But if you have a pseudo-relapse, or you're just having this fluctuation of symptoms, you do not need steroids. It is not going to help a thing. All it's going to do is cause trouble. Now, I want to just comment one more to the eye lady, so I just want to cast aspersions. So old optic atrophy, if you've had optic neuritis in the past, sometimes that's a little difficult to tell from glaucoma. But acute, if you have optic neuritis now, there should be easy to distinguish. So I just want to make sure about that before you run back and say something.
Okay, so I have a question. I asked Gretchen about the headaches, and I didn't see the migraines up there either. So is migraines not a symptom?
Not directly, no. Migraine is a different disorder that also affects young women. And so most likely, if somebody is having significant problems with headaches, they have a second disorder. So congratulations, you get another disorder that's very common. So it's very common for women in the same age group as have MS to have migraine. And so it's important to know that now, because we have great treatments for migraine now. It is a new world for people with migraine.
Okay, well, that's confusing, because that was like my only symptom.
Well, that's another problem. It doesn't mean that because you had a symptom, it's called the fallacy of what's called true, and unrelated. It's true you had headaches. It's true somebody did an MRI scan and discovered lesions on there. It's not necessarily true that they were related. So this is called, we even have a name called radiologically isolated syndrome. So we know that some people come to light as having MS accidentally because they got an MRI scan for their headaches. And lo and behold, it looked like what you saw on here are suggested MS, and we did a lumbar puncture, and sure enough, you have it. But what it means is it kind of got accidentally stumbled on, because everybody who comes to light with MS, whether it's some optic neuritis or walking problems or other things, because we can see the lesions on the MRI, we know they've actually had it for probably years. It's just there was no symptoms that came to light to make anybody want to do an MRI scan to look and see. But if you take the general population of young women, especially, probably 30% are going to have significant headaches. And in that population, there are going to be a certain number of people with MS. And if you do MRI scans frequently, you're going to pick up some people. Does not mean your headaches were due to the MS, or that the treatment for MS is going to make the headaches better. You need separate treatment.
Before I go to the next question, I want you all to know that MS Views and News recently started doing migraine programs. And we video recorded one recently by a migraine specialist from down in South Florida, Daniel Cantor. It's called Migraine Matters, and it's on our YouTube channel, and you could go there and you could listen to this entire presentation as well. And he also, correlates to a lot of what Dr. Hemphill just said, and you will learn a lot from it as well. Okay.
And it's important to understand. So look at the video with Dr. Cantor. I think it probably answers a lot of questions. It's important to know that you don't just sit back and hope that your MS treatment is going to help your headaches, because there's other specific treatment for migraine headaches, for migraine. It's a very important disorder that we have new treatments for.
We're now on this side of the room, and then I'll go back again.
Dr. Hemphill, could you elaborate on the damage to the kidneys that's caused by multiple or continuous UTI infections?
Well, yes, the plumbing, our plumbing, involves the kidneys, filtering out poisons, toxins, and then the water goes into the ureters, which are the drainage pipes that drain into the bladder, where it pools and sits and waits, so that the urine's not coming out all the time. So the bladder is sort of a repository, a bag. So the urine sits there, and then when it fills up enough, it sends a signal to us, and then there's a muscle, the muscles that work in coordination that help us to urinate and void, and the whole point of it is to try to empty the bladder out. And the bladder, it turns out, needs to be emptied frequently, adequately. If not, as I say, it kind of is like a pool of water here after a rain where the mosquitoes grow. So if you don't drain it out, you get the eggs hatching and you get mosquito larvae and all that. And the same happens in the urine, but it's with bacteria. And so if you're not emptying, part of the big function of the bladder, as I said earlier, is not only to help your comfort, but to clear the urine so it's not sitting there and allowing bacteria to grow. Now, if the bacteria grow in there, and also if the bladder is not working very well, the backs up, and it can actually go back and what's called reflux, and go back up those pipes to the kidney, and then that back pressure on the kidneys causes the kidneys to get bigger, called hydronephrosis, or it causes, if you're infected, have an infection, the bladder gets irritated and such, the bacteria go back in there and cause a kidney infection or pyelonephritis, and you can lose a kidney that way. So it's very important we screen for urinary tract infections frequently with urine specimens, and it's very important to treat those when we see them. Does that answer pretty much what?
I have to think about that with the mosquitoes and the larvae and every time I pee now.
You got to be from around here. Well, in Florida, Hey, Akeem.
Yeah, I have 3 questions.
Let's count on Akeem for good questions.
Yeah. Number 1, speaking of kidneys and everything, and as a male with MS, bladder is a major issue, but working where I work at, I can't go all the time. So are there exercises for males and for bladder exercises to control it, or is it best not to do that at all?
They're kind of the same as they are for females, actually. The pelvic floor exercises maybe a little bit to help with that. Unfortunately, the bladder it's what's called smooth muscle, and it's kind of involuntary. So the skeletal muscle, the kind you can build from exercises, is not that important. So the urologist will describe pelvic floor exercises. You can help some, but unfortunately, that's one area where exercise is probably not going to be as effective as it's going to be in other areas.
So before I take his next question, everybody should know also, on our YouTube channel, we have a pelvic floor exercise specialist who has also done a video on that too. I think if you go to our channel, you'll find whatever you want to know about MS, okay?
Question number 2. In current research with MS, are there any researchers trying to get signals to connect again with damage that has been lost?
Yes. No, that's a hot area. Regeneration is the word to look for. So you saw where the inflammation occurs, where the scars or the lesions occur. There's a lot of research in trying how do we stimulate myelin to grow back? How do we stimulate nerve cells to grow back? Because if these are denuded, kind of the thing I implied from a lot of this is that the nerve cell kind of withers. If it doesn't keep working, it's like your muscles. It just kind of withers up. And so there's a lot of research in how we can get nerve cells to regrow and how we can get myelin to regrow. From drugs that stimulate growth to the stem cell implants in the spinal cord that people have probably read about and get a lot of journalism press. But that's a hot area. It'll happen. We'll get there some point. A lot of the same research being used from people with spinal cord injuries and traumatic brain injuries and such also got me take an interest and support all those things because they all kind of play into the same mechanism by which repair occurs in the nervous system, whether it's from demyelination from MS or from a hemorrhage from a stroke or from an accident that's due to physical trauma.
How many days would you say, as far as an exacerbation goes, that you should, because you said days to weeks, I'm like, well, I mean, because my first symptom was neuritis. I waited like a week only because I didn't know what it was. But now that I am diagnosed with MS, I'm like, if I'm feeling tingling for, let's say, 2 days, should I wait that third day to see if it comes back? What's a good day to?
Yeah, probably so. I mean, if it's something subtle like numbness and tingling, I'd probably wait a little longer. You know, you want to know, not only know how long it is, but also is it new? Has ever had this before? So it's kind of that too. So that's the two criteria: is it new, and how long is it? What's the duration to determine whether there's a relapse? If it's a new symptom and it's lasting, I'd say more than, at least 24 hours, but more than a couple of days. If it's there 3-4 days or so and it's a new problem, again, if it's kind of subtle and it's a little bit of numbness and tingling, that's not going to be nearly as sort of dramatic and clearly a problem as if you just got this film over your eye and say, oh gosh, I can't see, my glasses don't help, I can't see out of this eye as well as I could 2 days ago. So that's going to be a little more clear cut. But because numbness and tingling especially, that's a whole, I could give a whole talk about the physiology of sensation and how our bodies kind of perceive sensations over time depending on our fatigue level, our sleep level, our mood and things. That kind of, it's a dynamic thing, not a static thing. So the brain actually has to suppress sensations. Otherwise, we'd all be hurting all the time. If it's touching, just banging up against anything would hurt. So our nervous system filters out all of this in various ways, and that mechanism kind of fluctuates over time. And so people experience, as a neurologist, I see people with numbness and tingling all the time, and most of the time we probably can't tell what it's from. It's just there. So with numbness and tingling, I'd say that's the kind of thing that unless it's here down and you know that's something new, yeah, I'd say, wait a few days and see how you do, and then, call and discuss it.
Okay, just 2 questions. I just learned something new. Ataxia, you said, is having the, like I'm having now, the ability not to speak clearly or get out your...
Oh, I'm sorry, Cassandra. Yeah, I may have kind of blurred things a little bit. So I kind of got into ataxia as the big category.
It is. My thing is the speech part. Like, even to getting closer to the end of the day, I can't get my words out.
Yes.
So I don't think that is a part of an exacerbation, I don't want to get on medicine, so what do you do?
Yeah, well, that's just the fatigue part. That's the Uthoff's thing. It's the physiologic stress sort of bringing out things.
And then one more question. I was looking at the MS magazine. I'm kind of trying to figure out how do you figure out from relapsing MS to progressive? How do you know? Everybody have all these issues that be going on. Yes, I'm getting deep. I would love to know, how do you know if it's from relapsing to progressive? How can you tell?
They get a lot of discussion on that. In my personal opinion and how I practice, I look at MS as more of a continuum. In the early years, it's more relapsing and inflammatory. That inflammation I told you about is much more likely to occur when you're in your 20s and 30s and 40s than it is in your 50s and 60s and 70s. Relapses are not very common as you get older. What does happen is what I told you earlier. That inflammation you had from your 20s and 30s and 40s leads to nerve cell loss or degeneration and atrophy, the brain volume loss, in your 50s and 60s and 70s, and causes. So it's kind of based on age. Again, autoimmune diseases, as I started out saying, tend to occur primarily in young women, and that's when we think MS starts really in just about everybody. So even though you didn't get diagnosed till you were 45 or 50, you probably had it since your 20s. You just weren't lucky enough to have an MRI scan to get diagnosed with it because we didn't have MRI scans, or you never had headaches. But you had MS, and you were just tired, and you didn't know why, but you did. And so we're using that with our medications now, kind of with using that understanding. And we know that MS is harder to treat the older you get and the more it becomes a degenerative disease rather than inflammatory disease. And so our goal is to treat it early when it's an inflammatory disease. That's when all our medications is working on that inflammation, because it doesn't work so well once things kind of start to degenerate or wither.
The majority of the medicines out there for MS, are they more targeting protecting the nerves and trying to rebuild the myelin, or killing the cells that are attacking the nerves, or?
We don't have any medicines now that directly help regenerate or stimulate the nerves. So the question is, do medicines more kill the cells that cause the inflammation or repair the nerves that have been damaged? Is that right? Is that what you're asking? So we don't have anything that directly stimulates repair right now, but that's what's in the works, as we talked about earlier. What we do know, though, is if you suppress the disease long enough and keep this inflammation from happening, after 4, 5, 6, 7 years, things start to get a little better. And so people sometimes complain, well, I took this medicine, the pills or infusions or shots or whatever, and I didn't feel any better. MS is a marathon, not a sprint. And so you're in it for the long haul. And so we know that if you do whatever you have to do to suppress the inflammation, you may have a chance to get regeneration. Now, in 5 to 10 years, we're probably going to have medicines to help with regeneration. Certainly that's being talked about, but we don't have it yet. The medicines we have now affect the immune system. Now, not all of them kill lymphocytes or immune cells. Some of them are what I call traffickers. They push the cells off, they keep it from crossing the blood-brain barrier, or they sequester the lymphocytes off the lymph nodes and don't let them get in the bloodstream. So they may have other mechanisms besides directly targeting and killing the immune cells. So not all of them do that.
With the medicines that you were just talking about, is there the ones that are killing versus making them move to the side, is there one that you're seeing works slightly better for a majority of people?
Well, that's beyond the scope of the conversation, really, to talk specifically about medicines. The way Sue's designed these is really to not talk about the disease-modifying treatments right now. I'll be happy to answer questions afterwards if you want. There's not one that's basically about MS, and a general rule you can use about treatment is that it's not a one-size-fits-all. It's going to be different for different individuals.
For me,
that's why we have so many.
Oh, yeah, I think. Dr. Hemphill.
Yes.
I was just thinking about something that somebody asked over there about from relapsing MS to progressive, and this thought just came to my mind. Because persons being diagnosed with MS, it affects them in so many different ways. Would you say, okay, you gave the example that most women especially are diagnosed between the ages of 20 and 50. When a person is diagnosed with MS, and it may seem like they're on the fast track, as I would say, for progressive MS. Is it because of other illnesses that may be a part of their system that causes them to fast track to progressive MS and not because of age?
That is a great question. Usually not. Usually, MS is different in everybody, as Gretchen said earlier. Not one person's MS is not the same as another's, and that is really kind of true about the course that it takes. I wish we had better predictors. We predict how MS is going to do, sort of how you present, how many lesions are already in your brain, how much inflammation is there, kind of what parts of the brain and spinal cord are involved. We kind of put all together in the hopper and kind of determine what we think your track is going to be. And if you think you're going to be on the fast track toward deterioration or losing function, we're going to treat that with a more aggressive drug than we think if you're going to be on a slow track. And so that's part of our calculation. But rarely is there ever another disease process involved. Now, people who have autoimmune diseases tend to have other autoimmune diseases, it turns out. So it turns out that people with MS, for example, women with MS may be a little more likely to have thyroid autoimmune diseases and such. So there is a little bit of clustering of autoimmune diseases, but almost, 99% of the time, if somebody has MS, whether they do poorly or not is not related to the presence of another disease process. It's just related to the course of MS that they've got.
Is there any relationship between MS and digestive problems such as acid reflux?
A good question. The relationship of MS and the digestive system, it's kind of like the migraine issue. Generally, there's not much relationship. Now, we're certainly understanding a lot more about bacteria in the gut and its relationship to the immune system. And there's lots we don't know. The reason we can't prescribe a diet that's good for people with MS is because we just don't understand enough of, there probably is one that's good, but we don't know what it is. And it's not because of whatever it's got in it that helps your body. It's probably whatever it's got in it that helps the bacteria. You want to get the right bacteria in your gut to grow to sort of help with your immune system. So there is a relationship between the digestive system and the immune system we're learning about. We don't have so much. It's sort of the other way around of the nervous system. It certainly affects your gut, but really your gut is sort of almost automatic and has its own little loop. And although stress and other things can affect it, turns out that the lesions that occur with MS, not so much. And so usually if there's a digestive system problem, we will look for other issues.
I'm sorry. I was diagnosed with MS in 1989, but I lived in England in the 70s for about 3 years. And when I was diagnosed in 89 in Savannah, I realized that the symptoms I had occurred in England. And so since then, several of my family members have been tested just to see if they had MS. Nobody has MS but me. And I was wondering about the England area. Is that one of the high regions?
It is.
It is? It is. Okay.
Yeah. So people in Great Britain, MS is common in Great Britain.
I just want to say thank you for all of this. It's very, very helpful. I'm grateful for the PT and for you, Dr. Hemphill. I learned something today. And my husband got one question. He wants to know
Let him ask.
You can't talk for him this time, Cassandra. You got to let him talk for himself.
She's going to make me laugh. But Dr. Hemphill, my question to you about MS, can a newborn baby have the disease of MS, and how would you find out if that was so?
It's a good question. No. I don't. I did actually. Reason I came to Savannah, my first time to Savannah, I made a presentation at the Child Neurology Society about MS in children and the spinal fluid in MS. But the earliest child I've known who started having symptoms of MS was 4. most all the kids with MS start with puberty at 12 or 13 or after. There are a few kids who are in the 7, 8, 9, 10. Fortunately, it's extremely rare. Other autoimmune problems occur. The way the newborn immune system is, it's protected and you don't get autoimmune diseases then. So no, MS does not occur in the newborn. It's an interesting issue about children overall, but not in.
Right. So when you're 17 years old, growing up to become that man or woman, and you go to your family doctor, is your family doctor, do he detect the discovery if you got it or not, where the child can get some treatment for it? Or how do y'all go about that?
Well, there's sort of two ways that MS really comes to light. One is that you have symptoms, all these things we talked about. And so the symptom leads you to a healthcare provider. That healthcare provider says, aha, I think this is a neurological problem, refers you usually to a neurologist or refers you for an MRI scan. And I mean, one of the reasons why MS we think now is much more common than it was is because of the MRI scan picking up on people with headache and other problems where it just accidentally gets picked up, or because people are kind of quick to get MRI scans for a lot of different symptoms. But the way it comes to light is either you have symptoms that suggest a neurological problem's going on, whether they think it's a stroke or MS or whatever, but it leads to a neurological evaluation, or you happen to get an MRI scan for some other purpose, like the young lady with headaches, and you just happens to turn up that you found it there. So it's usually those two ways. But you can't expect a primary care doctor just to know it's there unless you have specific symptoms.
We only have time for 2 more questions. The first one's going to be right here, okay?
Dr. Hemphill, you talked about the progression of the disease and early on in the 20s and 30s and inflammation, and then as you get older, less exacerbations. So would you say that someone who's had a pretty good course and diagnosed for 25 years and now in your 50s, would you say that that patient might be advised to stop treatment?
Well, that's a different story. Well, I'm not going to go that far. No, I'm not going to say that. For right now, we think that people who have MS, we don't know when is a good time to stop in anybody. So that's a big question. It's a big issue that comes up, and neurologists debate that. As far as we know, because we know it can slowly progress over time, and we don't know why that progression or degeneration occurs, there are a lot of people who think there's still some low-level inflammation going on. Not the big inflammation that we see that would cause the MRI scan to show the contrast dye crossing the blood-brain barrier and that sort of thing, but maybe there's a low-grade inflammation that goes on, and so we continue to treat MS even into the 70s. And so right now we just don't know when to stop, and we're afraid to because we know that it can continue to get worse. And so stay tuned. Hopefully we'll have more information about that as we go along, but that's just frankly one of the areas we don't know enough about.
All right, so now I have the last question. I have to be that one. Everybody satisfied with this program? Thank you. Let's thank Dr. Hemphill also.
Thank you.
Great.
Thank you, guys.
Thank you. Thank you very much.